training at UCLA and has a robust practice at Palo Alto Medical Foundation. And with Dr. Lin doing the lower half of motility, we figured it'd be great to kind of get an update on esophageal motility from Nick. So thank you, Nick.
Thank you, Suraj, and thank you to the board for having me. So as Suraj suggested, I've been asked to speak on esophageal motility, which would nicely complement what Mimi talked about. I think if you miss one meeting in the IBD world, you probably forget about 5 or 6 new drugs in motility. You can go in a coma for a few years and things don't move that fast. So I'll do my best. Hopefully there's some new stuff that you guys can learn about. So these are my disclosures. So I think the major update that's happened more recently is an update to the Chicago classification. So I'm going to spend the majority of my time talking about that, as well as using that as a framework for a few additional studies that have come out more recently. So the newest iteration came out last year, version 4.0. And with that, there's been an update to the protocol. So previously, it was mainly just 10 wet swallows in the supine position. Whereas now, in addition to the supine position, you're doing also multiple rapid sequence swallowing afterwards supine, followed by 5 swallows in an upright position, and then also a rapid drink challenge where 2 mLs are drinking really fast. And so with that, there seems to be some clarification, particularly with disorders of EGJ outflow, which has kind of been problematic for some of the earlier iterations of the Chicago classification. And then there's also been some minor changes with the disorders of peristalsis as well, which we can talk about. So this is a busy slide, but this kind of highlights the differences between the Chicago classification 3.0 and 4.0. And as you can see with achalasia, it's pretty much the same as regards to the definition. The main differences are for EGJ outflow obstruction. So with that, you need to see an elevated median IRP both in the supine position as well as the upright position. Also, there should be an increased intrabolus pressure in the supine position. And I think one of the more important things is they've added symptoms to this. So in addition to having findings of EGJ outflow obstruction, which we often see on manometry, these patients really need to have chest pain or dysphagia present. And if all of those are present, then that's where you would want to move on to a confirmatory study, such as endoflip or barium esophagram. With the disorders of peristalsis, similarly, they mostly look the same. I think the main difference is for DES and for hypercontractile esophagus, there needs to be the presence of chest pain or dysphagia as well. And then with the ineffective esophageal motility, the definitions changed a little bit more, where there's now 70% ineffective swallows or greater than 50% failed swallows. So this is a nice little flow chart kind of describing all the different diagnoses that can come from esophageal manometry. So the main first step is whether there's an abnormal median IRP, which is usually 15 in the supine position. So if they have an elevated median IRP greater than 15 and there's no peristalsis, then you're looking at achalasia. If there is an elevated IRP but normal peristalsis, then that's where you want to kind of differentiate whether this is true EGJ outflow obstruction or not. So if it's not already done, you want to do swallows in a second position, consider the multiple rapid sequence swallowing, as well as rapid drink challenge. And if the LES IRP is still elevated, then that's when you want to do confirmatory testing with either barium esophagram, preferably with a barium tablet or endoflip. And if the IRP is normal, that's where you're looking at disorders of peristalsis, which are defined there. If at the end things look normal, this is not usually done in a lot of centers, but if things are normal and you're still suspecting some sort of swallowing disorder, then that's when you want to consider meal challenges, and you can use a solid meal to see if there's any abnormalities in their motility. That's also helpful for rumination or kind of postprandial disorders as well. So these are the achalasia subtypes. And so you can see the bottom is the LES and how it relaxes. And in all three of these subtypes, the IRP is elevated. It's greater than 15. You can also see it doesn't completely relax. There's also an absence of peristalsis in all three of these subtypes. On the left is type 1 achalasia. That's kind of your classic achalasia where you, on endoscopy, you see a really dilated esophagus, tortuous esophagus. There's virtually no activity, as you can see on that left panel. Type 2 achalasia, you'll see these pan-esophageal pressurizations. And then type 3 is the spastic achalasia, where you can see there's a rapid contraction with a short distal latency period of less than 4.5. So these are the kind of three major subtypes of achalasia, and obviously can have some potential implications in how they're treated. This is absent contractility, which can be inconclusive for achalasia. So in this one, you see there's virtually no activity at all in the esophagus. The IRP is normal here, but if you do, it is recommended to do some sort of supportive testing in these groups. So you can see on the time barium esophagram, you actually see a quite dilated esophagus with stasis of barium in the lower esophagus, and then kind of that rat tail or bird's beak appearance lower down. So that looks more like achalasia. If you do flip on these studies, and so for those of you who aren't familiar with endoflip, it's a soft balloon that primarily measures the main thing we look at for that is what's called the distensibility index, which accounts for surface area as well as intrabolus pressure at the LES. And in someone with achalasia or poor distensibility of the LES, that distensibility index will be low. So that's a good confirmatory study as well for this. So this is EGJ outlet obstruction. And so what we most commonly see is the middle panel where there's an elevated IRP, but otherwise peristalsis looks pretty good. And this is, one of the more challenging kind of things we find in manometry where often if it's not, if I'm reading this and it's not one of my patients, I can often get lost in the chart looking for a good reason for this. So the new iteration is nice where they have a little bit more stricter diagnoses around this. But the main concern is this early achalasia or some sort of achalasia subtype. But you can also see it with hiatal hernia. You can see it with a stricture or other kind of obstructive process. It can be from extrinsic pressure. So if there's some sort of abnormality of the aorta or heart, it can also press on the esophagus looking like that. You can also see EGJ outlet obstruction with hypercontractile features on the left where the DCI is quite elevated. And then on the right, what we see is an artifactual rise where this patient, if you actually change their position, the IRP would return to normal. So something that's a little bit more challenging. And again, with the newest iteration of the Chicago classification, you really want to make sure they have symptoms suggestive of this, such as chest pain or dysphagia. So these are kind of the more common disorders of peristalsis, absent contractility, which you may see in a connective tissue disorder like scleroderma, ineffective esophageal swallows. A normal DCI is greater than 450. So in here, it's weak peristalsis. The third panel is there's a large peristaltic break. So both of those, if those were present in 70% of the swallows, would qualify as ineffective esophageal motility, which is a minor disorder of peristalsis. We do see it in normal individuals. We do see it in GERD. We do see it in connective tissue disorders. So that can also be, kind of a common finding of unclear clinical significance, as they say. And then on the right is an example of a multiple rapid swallow. So in this patient, you give them 2 milliliters swallows 2 seconds apart times 5. And what you normally see is deglutitive inhibition, which you can see on the left. So from frequent swallowing, it actually impairs peristalsis. So you shouldn't see any peristalsis during that MRS sequence. But then afterwards, you get this a little bit more robust swallow than what you normally see. So in this patient, they actually have a normal swallow as before they had a weak one. So that's a finding of normal contractile augmentation. So on the left is distal esophageal spasm. So distal latency, which is a measure of how long it takes for the swallow to go from initiation to a change in the inflection point, which is right where the bottom of that line is. So normal is 4.5 seconds. So there it's kind of a rapid one. So you could see it looks more upright than what you would see with normal peristalsis. And then hypercontractile esophagus, which was formerly called jackhammer and before that nutcracker. But what that is a DCI greater than 8,000. And so the main difference here is that symptoms need to be present, chest pain or dysphagia. There are 3 subtypes, as you can see there. The most common one we see is on the left, where there's just an elevated DCI, but jackhammer came from the appearance on a manometry where it looks like a jackhammer is kind of drilling into the esophagus there, and you get an up and down pattern. So with that framework in mind, there has been some few studies that have come out in the past year, as well as with DDW. And so, I thought one thing that was interesting is we have these kind of major findings with esophageal manometry, and then we have some of these minor findings of unclear clinical significance. How often do you see these in asymptomatic individuals? So this was a multi-center study where their aim was to kind of assess what's the prevalence of these abnormalities in healthy asymptomatic individuals. And I could tell you, when I was an eager young fellow and I agreed to be a healthy control on a manometry study, these are not fun studies at all. So I'm not sure how they found so many individuals. So these were healthy individuals solicited from motility centers, symptomatic patients, prior surgeries or chronic diseases were excluded. And these were mainly with the Medtronic solid state catheters. And all of the studies were analyzed de novo by 2 of the investigators. And they found 469 healthy controls total. The majority of them were normal, about 75%, but 15% had ineffective esophageal motility. So pretty common finding even amongst normal individuals. And then EGJ outlet obstruction was found in 5.3%. So another pretty common finding, but none had achalasia and none had hypercontractile esophagus or any of the major findings. So in conclusion, what you can see is ineffective esophageal motility can be common in asymptomatic patients. EGJ outlet obstruction can also be common. So you want to make sure in those who you think it's real, you want to do confirmatory testing with most likely barium esophagram or endoflip if you have it available, or exclude other causes like a hiatal hernia or something like that. And then major disorders of peristalsis are exceedingly uncommon in asymptomatic patients. So with the EGJ outflow obstruction in mind, the newer iteration of the Chicago classification looks at these additional techniques such as multiple rapid swallows and rapid drink challenge to see if they can really parse out some of these true findings. So this was a study out of Northwestern, as well as China and Penn, where they looked at these 2 maneuvers and its effect on the outlet obstruction. So EGJ outlet obstruction can be a common finding in high resolution manometry. It encompasses a broad range of diagnoses. Most of the time it's normal, but I think the main concern is this early achalasia or some sort of achalasia variant. Confirmatory testing with imaging or flips often needed, but there are now maneuvers like multiple rapid sequence and rapid drink challenge, which help differentiate these. So this was a retrospective study where they looked at these patients with EGJ outflow obstruction based on the earlier Chicago classification version 3. Prior surgeries and mechanical obstructions were excluded. And these patients underwent a standard high resolution protocol along with the MRS and RDC. And so the way they did the multiple rapid sequence swallowing was 2 mLs of water for 5 swallows, 2 to 3 seconds apart. And then the RDC is 200 mLs as fast as possible in an upright position. And all of these patients had a barium esophagram as well. And with the about 100 patients they found, 32 patients had radiographic evidence of EGJ outflow obstruction. But what they found is that with an IRP greater than 12, with both MRS and RDC, they were twice as likely to have radiographic evidence of EGJ outflow obstruction. So if your motility center or where you're referring does this, it can help kind of parse out some of the true EGJ outflow obstruction. So one thing to consider, but I would still consider confirmatory testing in those that you think they still have some sort of outflow obstruction. All right, and then lastly, one of the things the new version of the Chicago classification touches on is the effect of opioids on esophageal manometry. So this study looked at the opioid exposure and how it affects the lower esophageal sphincter. So we all know that long-term opioid use is often associated with dysphagia and motility disorders of the esophagus. But what are the impacts of opioid exposure and what are the manometric characteristics? So in patients who underwent high-resolution manometry from 2007 to 2018, demographics, opioid exposure, and manometry findings were compared. PROMIS GI as well as Eckhart, which is just kind of a swallow score, were obtained in those with spastic disorders. And what they found in out of over 4,000 patients, 869 had opioid exposure to some degree. And those patients on opioids were more likely to have dysphagia, 65 to 51%. They were more likely to have spasm, and they were more likely to have hypercontractile esophagus. Interestingly, partial opioid agonists were not associated with any motility abnormalities. And in those who were on opioids, they had higher symptom burden compared to those who were not on opioids. So in conclusion, about 2/3 of patients with opioid use undergoing high resolution manometry had dysphagia. A high proportion of them had spasm or hypercontractile esophagus, and there was higher disease burden. So you really want to try and for those you're referring for manometry, you want to make sure they hold their manometry, or excuse me, hold their opioids if possible for at least 48 hours, or at least based on the half-life of their opioids. These patients do not do well with surgery. So if they do have achalasia or nutcracker type findings or HE type findings, you really want to try and avoid POEM or Heller myotomy in these patients. And if possible, consider switching them to buprenorphine or tramadol or one of the partial opioid agonists. And I think that's it for my part. Yeah, so I'll take any questions if anyone has any. Yeah.
Quick question, I speak loud. When you read the manometry, can you walk us through how do you read one high resolution manometry with the scanning when you do it? You look at the pictures.
Yeah, I think both. I mean, yeah, I mean, I think both. I mean, one of the cool things about manometry is it's kind of like pattern recognition. So you can look at one picture and it's like memory when you're a kid. You can kind of see, what pattern it looks like. So something like achalasia is going to be really tough to miss as long as the catheter goes through the LES and you get a good tolerance of the study. But what we usually do is, we look at the resting pressures. So there's kind of an accommodation period followed by a resting period where for 30 seconds, you just try and capture without the patient swallowing or gagging, what their kind of resting LES pressure looks like. And then the way I look at it is I look through each swallow individually. So through the next 10 wet swallows, you want to see how well the LES looks, whether it relaxes, whether there's normal peristalsis with each of these swallows. If you do have a catheter with impedance, you can turn on the impedance and see how well the bolus goes through the LES as well. And then after you look at those swallows, then you can look at the numbers and see if there's any abnormalities in the numbers. But if you do it that way, where you kind of do it systematically, you're usually not going to miss the major things like achalasia or hypercontractile esophagus. It can be tough when someone has poor tolerance of the procedure, where they're just coughing and gagging and swallowing a lot. That's where you can get a lot of overreads on ineffective motility and some of these other things. But that's kind of how I approach it. Any other questions?